And welcome. First things first, and that's the disclosure. I do have relevant financial relationship with BioReference Health. They are a subsidiary of OPKO Health Diagnostics Division, and OPKO Health, through their pharmaceutical division, produces products used on patients. So we'll start out here with a quick comment about the general disclaimer. Information offered in this presentation is meant to educate on industry practices in coding and billing as it pertains to the practice of pathology. And anyone utilizing the information presented here today is encouraged to perform their own due diligence to evaluate resources and ensure information will remain current at any future date, and to evaluate the impact to the specific circumstances of their business. Now, finally, the recommendation would be to seek out qualified professionals when specific questions arise with regard to billing, coding, or documentation practices. And a gentle reminder, the American Medical Association, or the AMA, does own and manage the CPT nomenclature, which is utilized in this presentation. And we are utilizing it for the limited purpose of promoting education of the attendees, and as it relates to a CPT code reported on an industry standard claim form. So it is also that time to remind you of the new CPT code books. It's the end of 2026, or excuse me, it's the end of 2025, I guess. And we should have in hand our CPT code books for 2026. There we go. This title for today's session is Nuances of Billing for Pathology CPT Coding. And I am Robin Miller-Zweifel, and I am currently with BioReference Health as the Director of Coding and Billing Compliance. I have over 25 years of experience in revenue cycle management of laboratory and pathology services, and I serve as a member of the College of American Pathologists, and I am a non-physician member of their practice management committee, and as an advisory member to the board of American Pathology Foundation, or the APF, where I also serve as editor-in-chief for the APF Pathology Services Coding Handbook, working closely with my co-editor to oversee the handbook's content. The agenda for today is the discussion of definitions for how do we determine a specimen, and then looking at units of service for billing of those specimens, and also looking at documentation, report formats, and just some of the general rules around billing for these particular CPT codes, and then having a little bit more detailed conversation around the fine needle aspiration biopsy and some comparison to the core needle biopsies. So educational objectives for today, hopefully to enhance knowledge of what defines a tissue specimen and the unit of service for billing. Then awareness of payer guidelines and documentation requirements. Again, hopefully improve understanding of documentation for the FNA biopsy and the billing of those procedures. And then to gain a usefulness of the tips for CPT coding. So starting with a discussion of specimen, and how does the AMA or other entities define a specimen for pathology services? So the AMA CPT pathology coding changes for 1992. The unit of service for tissue in the pathology lab is the specimen. The AMA further defines a specimen as tissue or tissues that are submitted for individual and separate attention. So that's really the key part of that phrase, is that they are submitted to pathology for individual and separate attention. And they require individual examination and pathologic diagnosis. When material received for pathologic examination comprises multiple specimens, each specimen is a single unit of service and is to be reported using a single CPT code. But now we'll have to look a little bit more detail of how we substantiate those multiple specimens as being separately billable with their own unique CPT code. So moving forward right now, so we're going to jump from 1992 back up to 2025 and look at CMS National Correct Coding Policy Manual. And there we find that the NCCI specifies that the unit of service for gross and microscopic surgical pathology codes, pathology consultation during surgery, electron microscopy, and for morphometric analysis, those CPT codes are all based on the definition of a specimen. So the NCCI also defines a specimen as tissue or tissues that are submitted for individual and separate attention, examination, and diagnosis. So we have agreement so far. And the NCCI policy manual does emphasize that it must be medically reasonable and necessary to submit the specimens for individual attention, examination, and diagnosis. So, for example, to be medically indicated or medically reasonable, if colonoscopy identifies two separate polyps at 15 centimeters and 25 centimeters, it may be medically reasonable and necessary to submit them as separate specimens, such that if one of the polyps is malignant, it would be of importance in the future for the diagnosing and treating physicians to know which of those polyps is malignant. So to differentiate biopsies of a separate polyp versus multiple biopsies of the same polyp. So when there are multiple biopsies of the same polyp, they are usually submitted as a single container and are going to be billable as a unit of service. So we're going to rock back and forth here a little bit. So rolling back to 1992 for a moment, the AMA's first guidelines for pathology coding, when a cell block is prepared from cytology fluids or from washings or from a bone marrow aspirate or for a fine needle aspirate, it is appropriate to code each of the cell blocks as 88305. So I want to clarify here right now, that's based on the source. So a cell block from a source is codable as 88305. If you have multiple sources, then it is appropriate to code each of those cell blocks. And we'll talk about that in a little more detail as we go through the presentation. So next on slide 12, we have two skin lesions that have been submitted in a single container. There is no unique identifier. And although the pathologist may or may not, but most likely will separately evaluate and diagnose the tissues, they are not separately identified when they arrive in the laboratory. They're not labeled individually, and they are submitted in a single container. So in this instance, the work of the pathologist is going to be billed as a single specimen with CPT code 88305. Moving on with that same AMA reference point from 1992, now I have two skin lesions from the scalp. Each is placed in an individual container. each is individually and separately identified. So the key words here, they are individual and they are separate. One is pigmented, it's a pigmented skin nodule, and the other is an inclusion cyst. And the physician service involved with the pigmented skin nodule is going to be coded as 88305, while the physician efforts involved in the inclusion cyst are going to be coded as 88304. So that's a skin cyst tag or debridement code. And continue with that same resource. Now we have multiple skin biopsies in a single container, but they are uniquely identified. When two specimens are distinguished for separate evaluation and diagnosis of both specimens can be coded if all of the criteria of examination and diagnosis have been met. So I have two biopsies. I can differentiate them because one has a stitch, the other one does not, or a suture, I guess I shouldn't say stitch. And as long as the pathologist identifies them separately in the pathology report, and I have distinct diagnosis statements for each of those two specimens, then I can code 2 units of 88305. Now here we're in 2011, so it's an AMA CPT assistant that was published in 2011. And this was part of a special Q&A that was issued that year. So this question is in regard to the gallbladder. So the gallbladder has a single CPT code. It is 88304, and that is regardless of whether the work is associated with a complex gallbladder case or if it's a standard routine gallbladder. All right, so the question though is, if I have a complex gallbladder, can this be upcoded from an 88304 to an 88305? And the AMA in their response explains that generally speaking, the CPT codes for our gross and microscopic tissues increase with complexity as the CPT code sequence increases in number. And that is designed in order to capture the work efforts of the pathologist. So when assigning a code, one must refer to the listed specimen types. And if a description of the specimen that is being coded is specified in that list, then that is the CPT code that should be used. And in this case, 88304 does list the gallbladder, and therefore 88304 is the most appropriate CPT code. Now, note that there are some code descriptors that will differentiate between a malignant versus a benign condition. But in the case of the gallbladder, that does not apply. So 88304 is our CPT code, and it does not matter if I have a neoplastic or a non-neoplastic specimen. I am not going to upcode. Only when the definition of the CPT code includes reference to that malignancy, or it designates that it is a neoplastic specimen. That is the only time that we're changing and increasing the level of CPT code, is if by specificity of the tissue listed, that also has a secondary qualifier of the malignancy. I think, and before I move on, though, I do want to comment that the additional work with those more complex cases, generally you're going to be capturing that work with the stains. You would typically, with a more complex case, have at least special stains, probably an IHC, maybe two, maybe a multiplex. So the additional work is represented in those ancillary services, not necessarily in the level of the tissue. Okay, so now moving on to the discussion of units of service. And we're going to start here with the discussion of a cell block. And from 2005, the AMA had published an article about surgical pathology coding from July of 2005. And here the AMA reiterated the unit of service for a cell block is the specimen. So the unit of service for the code 88305 for a single specimen will not be multiplied irrespective of the number of cell blocks that is prepared from a single specimen or tissue. Therefore, if a pleural fluid sample contains sufficient material to prepare a cell block, the code used for the preparation is 1 unit of 88305, whether 1, 2, 3, or maybe more cell blocks are prepared from that one single pleural fluid sample. 88305 would only be billed 1 time. Now, also in 2005, the College of American Pathology addressed the fine needle aspirate when a cell block is prepared from the residual fluid. And in this example, the CAPS response supports that the pathologist may separately bill 2 units of 88305 because I have a core biopsy for the bone, and the second unit of service is assigned to the cell block, which is prepared from the residual fluid of the FNA, and that is being submitted for a histological evaluation using that cell block. So additionally, the cytopathology evaluation of the fine needle aspirate is going to be coded as 88173. And the decalcification of the bone is also coded with an 88311. So in this specific instance, you will see the 2 units of 88305, but one of those units represents a core biopsy of the bone that was collected, and then also an 88305 for the cell block, which is prepared from the residual fluids of an FNA. Here from a coding consultation on surgical pathology that was issued in September of 2000. The unit of service for the surgical pathology codes 88300 through 309 is the specimen. A specimen is defined as the tissue or tissues that are submitted for the individual and separate attention and requiring that individual examination and pathologic diagnosis. So again, we see that the AMA is staying consistent with that definition of a specimen. And this is in agreement so far with really what we've seen from the College of American Pathology as well as the NCCI policy. So therefore, when material received for pathologic examination comprises multiple specimens, each specimen is considered a single unit of service and should be reported using a single code. For example, if 2 separate skin lesions are separately identified and submitted in a single container, the physician work related to each of these separately identified specimens would be reported as 2 units of 88305. However, if 2 separate skin lesions are submitted together and they cannot be separately identified, so they're not distinguishable, then this would be reported as a single specimen as 1 unit of service, reported as 88305. And stepping back again to 1992, here we see on slide 21 an example of 2 different scenarios. Now we have endoscopy biopsies that are separately submitted in individual containers and each is labeled as to the source of the tissue specimen. In the second scenario, again, it is the endoscopic biopsies, but they are submitted in one single container. So in scenario one, I have 3 billable units of 88305, while in scenario two, I have only 1 unit of service that I can bill for 88305. It really comes down to the packaging and the labeling of the specimen that is going to determine the way that the specimens for pathology are going to be counted, going to be coded, and billed. So from there, we're going to move on and talk about documentation and how is the report going to play a role in supporting both the level of service and the number of billed service units that we can have on that claim. So the documentation as applicable, right? Understanding that not all different specimens require each of these pieces of detail, but as much as possible should be included in the final pathology report. And that should be the clinical history, itemization of each specimen that was received and analyzed, and that itemization should correlate to what was on the labeling and on the specimen request. So there's continuity of that documentation. Obviously, it should list the specimen source. And then the report should reference and provide any result of all intraoperative consults or the preliminary exams. And then as that tissue is into the laboratory, we should have a section in the report for gross tissue description, microscopic tissue description, and then any special stains or IHC procedures, including the positive and negative results. Also, if you're doing other ancillary testing, if you're ordering some molecular test or some flow cytometry, all of that should be referenced in the report. And there should be a diagnosis for each individually listed specimen. And then we should associate stain results to that diagnosis per specimen. So if the stain or an IHC, if there is something of particular association with a specimen, it should be demonstrated in the report as being associated to that specimen and should inform how those results lent themselves to the diagnosis as well. So whether a specimen from surgery was examined and diagnosed by a pathologist should be self-evident within his or her medical report. So the physical findings from the macroscopic review of the tissue should be recorded in a dedicated section of the report. And it should be labeled as the gross description or the macroscopic description. And then whether or not the tissue is subjected to microscopic exam should also be in a dedicated section of the report, and it should give me the details of that microscopic exam. If 2 or more pieces of tissue are in one container and they're anatomically or conceptually different from one another, then each of those should be individually described due to the possibility that a separate charge could be applied. Now, it's necessary, or excuse me, I guess it's not necessary, that separate specimens be placed in individual cassettes in order to maintain their uniqueness. But I do need to have those specimens identified on the report if they are expected to be potentially charged separately. So if there's additional markings, if there's additional ways to differentiate those specimens, such as maybe if a sample is inked or in some way able to be separately identified and distinguished in the report, that should be listed, and the details of how you're distinguishing that sample should then again be associated with the surgical note. It should be somehow associated back to the labeling and the request because we're looking for continuity, and your coding and billing department, as well as any subsequent auditors, need to be able to follow that documentation trail. Then there needs to be a final diagnosis section of the pathology report. Many times that final diagnosis and microscopic may be combined together, where I get the details of the microscopic as well as the diagnosis statement. But we do need to make sure that we have a medical observation. What is that conclusion and the interpretive findings for each of the specimens in order for those specimens to be billable? And as a rule of thumb, I like to adopt a very strict rule of thumb, actually, that says if it is not sufficiently documented within the pathology report, then it cannot be coded. And if it cannot be coded, it cannot be billed. So on this next slide, we're on slide 25. This is an example of a vacuum-assisted breast biopsy report. And excuse me, in this particular case, there were 7 cores that were submitted within one container. Now, that container includes a filter cartridge, I guess is the best way I know how to describe that. And that cartridge is then separated into 12 individual segments. But it is one container that arrives in the laboratory with a label. And if necessary, the radiologist or the proceduralist has the opportunity to visualize through imaging if there is something particular in one of those cores that they would like to call out or identify for separate attention. But in this particular case, I have one container. It has a very sort of generic description for the 7 cores that are contained within. And I have one diagnostic statement, and my IHCs are generalized. I'm not really able to tell which of the the chambers or which of the cores were selected for that stain. So from my review of the work and my examination of the report, I was not able to bill any more than 1 unit of service for those 7 cores. Now, when I correlate that back to the surgical procedure that was performed for the vacuum-assisted breast biopsy, I was also able to identify that there were no additional lesions that were biopsied. So this work was, the cores were taken from one single lesion. And that too also led me to a determination of billing only 1 unit of service of 88305. So for a little bit more detail in looking at this procedure as a whole, you see there on the right-hand side, the cartridge that has the individualized segments, but in the bottom left corner is the container. It's a single cup. That filter cartridge is inside of that container cup, and I have 1 container. Unless otherwise designated, then that counts as 1 single specimen. Yeah. So now we're going to move into some review of payer edits and a little bit of information around rates for the hospital versus physician and just kind of how to go about that comparison. So starting out here on slide 28, we're looking at a global billing scenario. So I don't have a TCPC splittable to look at for my non-facility pricing. I'm looking at a global, and this is the national rate. I will point your attention to the facility price, and you'll see that it's an NA, not applicable, because if I'm a global biller, I don't have a hospital originating specimen. So there's not going to be a facility price associated with this line on the Medicare physician fee schedule. So giving you though just this comparison and looking at the units of service. So my MUE is my medically unlikely edit. It's my maximum allowable units for consideration of reimbursement, unless there's a special circumstance. And a special circumstance is going to require an appeal. So with an MAI, my MUE adjudication indicator, that's what that stands for. I have an MAI of 3, which is based on clinical data. And that combination of the MAI of 3 allows me to appeal and challenge a decision if I have a special circumstance that I exceed the standard MUE of 5. As you look down through the CPT code list, you'll see there are varying MUEs based on the type of service. I would call out your attention to 88305 that allows up to a unit of 16. Do be aware that um, payers will have specific limitations that may be lesser than 16 allowed units of service on a single day for 88305. And many times those payers will publish limitations that correlate with the diagnosis code. So if it's a gastric diagnosis code, the payer may allow 12 units of service. If it is a prostate diagnosis code, they may have 0 allowed units of service on 88305 because they require use of G0416. So you'll need to get very granular in looking at your allowed units of service based on individual payer policies. But again, wanted to bring to your attention that on the right-hand side under the green header, this is a comparison of how the hospital MUE values align. And you'll see there are some variances there. So starting out with the FNAs, the 88172, there's a discrepancy between 5 units of service for the professional claim and a allowable of 7 units of service on the facility claim. The same for the 88173 for your diagnostic exam of that FNA. Now, the anomaly comes in on 88177, where you have the allowable units of 6 on the professional claim and a unit of 1 on the institution or hospital's claim. And the reason for that is really an anomaly that comes out of the OPPS data and the packaged payment system, where 8177 isn't a separately paid code, and it ends up reflecting back in this MUE information. On the next slide, so looking at slide 29, this is first of all, these are the procedure to procedure edits. They're pulled in this example from the physician edit tables to let you know there is a separate edit table for hospitals, but these edits are going to be very similar between the physician and the hospital. So procedure to procedure edits is the column 1 CPT code is your payable CPT code. But if on the same day of service, the column 2 code appears on the claim, then there is going to be a claim edit because these codes are considered not to be billable for the same specimen or for the same procedure. And if you're billing for both of these CPT codes, you would need to append a modifier, and the modifier would rely on documentation in the pathology report to provide distinguishing information that would allow billing of the 2 CPT codes. So a little bit more definition there, starting with 88172. you see that the codes that are conflicting there are going to be related to some other type of an intraoperative consultation or a touch prep. So those are similar, and I'm not going to have a FNA, which is on a fluid sample, versus a touch prep, an 88334 or something of that nature, where I have a tissue sample, or my intraoperative surgical consult is not going to be for the same consultation that I'm doing for the immediate evaluation of an FNA for adequacy. So those are where you're looking at conflict. And if I'm going to build both of those CPT codes, I need documentation in the pathology report that explains to me the two distinctly different scenarios that the pathologist was involved in that consultation during that day. If you follow that list on down towards the bottom, you'll see 88184, which is for my flow cytometry, and 88342, which is an IHC stain. According to the NCCI policy for same and similar, my flow cytometry and my IHC, if I am using both methods for the same marker, then that is considered to be duplicative testing. If I am going to have the same marker performed by flow cytometry and by IHC, I would be looking for my pathology report to explain why both are necessary for diagnostic purposes. If my flow cytometry is that based on the result and correlation to clinical indications and expected diagnosis, there is not the ability to confirm and arrive at a definitive diagnosis without now having an IHC result as well, then that needs to be stated in the pathology report. Otherwise, I'm not going to be able to substantiate that charge and put a modifier on the IHC stain. And without a modifier, I'm not going to be able to bill that additional charge. So all of this is going to fall back to the pathologist report and documentation of medical necessity, reasonableness, and indications. Now on slide 30, this is a comparison of payment rates for the technical component work that is in the independent setting versus the facility component of the hospital, which is on the right-hand side of this slide in the green header. Note that for the TC build on a professional claim, the rate is only available for the non-facility setting, right? Because again, that whole discussion around the TC component of professional billing will not be associated on a Medicare claim for a hospital originating specimen, because that technical component, according to guidelines, must be billed on the hospital's claim. But again, this slide is just to give you that comparison of the reimbursements and sort of to understand where that overhead of the hospital can aid in what the reimbursement rates are established at for the hospital. But what I would point out to you, excuse me one moment. What I would point out to you here is that in the hospital setting, under the OPPS, those payments are going to be packaged more than likely. And what that means is that during the surgical encounter where these specimens were collected, the surgery itself as the primary procedure is going to have a reimbursement rate associated with the surgery. The ancillary services now are packaged into that surgery rate, and the laboratory, the pathology services are not going to have a separate reimbursement on that EOB. Okay, so now let's focus on the specific procedure coding. And for this, I've selected to talk about fine needle aspirates and fine needle core biopsies. And sometimes that documentation can be very confusing and misleading when we're looking to be able to code for the pathology review. So in 2019, the AMA defined the FNA as a cytologic specimen for examination of cells. And in comparison, the core biopsy is a sample of tissue for histopathologic evaluation. And while the AMA CPT assistance references to a larger bore needle for that core needle biopsy, there is no specified gauge that has to be used for that fine needle biopsy. So really, it's a matter of having those specimens clearly identified at the point that they are collected. And many times there may be the use of a very fine gauge needle in order to go in and obtain a core needle of tissue for biopsy. So we're really not able to rely on the gauge of the needle. It's purely based on documentation of the procedure and looking to see how that procedure for the surgical approach is coded and billed. So coordination with the physician that has performed the surgical procedure to me is of benefit, although in some settings we don't have that access, right? So if you're in an independent laboratory, you don't have access to the medical record, you don't have ready access to the physician that collected that sample. But if you do have that access, it is very beneficial. And then looking at the comparison of how the surgical approach was documented, how it was coded, what were the notes by the collecting physician versus what you receive on the request and what you see in the pathology report. So that coordination, and if you're having confusion in trying to get the labeling of an FNA aspiration, right? That fluid that comes in as an FNA biopsy versus a very fine needle core biopsy. If there's confusion there, what I find is generally that confusion begins in the surgical suite with the staff responsible for labeling specimens and for documenting the request. So coordination, education, communication, all of those things. As much as you can coordinate and communicate, the better your coding and your documentation will be in the end. So when there is question as to whether the specimen submitted is intended to be a fine needle aspirate or if it's a core biopsy for histology, it is sometimes necessary to confirm against how that surgical procedure was coded. But I want to point out to you here on slide 34, these are CPT codes or ranges of CPT codes that have been cited as errors in coding for the surgical procedure because the definition of these CPT codes refers to the needle that would be used. You would want, oh, wait a minute, I think I'm on the wrong slide. No, so this is, so sorry, these are not sorry, these are not the approaches that have errors associated with it. So these would be the percutaneous needle biopsy aspirations. So these would be aligned with what you would more than likely receive for a histology procedure. And I'll get this straight in just a moment. I apologize. I had gotten off on the wrong topic. So the next slide here on slide 35, these are, if you have a fine needle aspiration, these will be the approach. So this is the surgical approach and whether it is performed with guidance or without guidance. And then if it's with guidance, the specific modality for that guidance. So again, gives you some definition to the CPT codes for that surgical procedure. Now then, this information on slide 36, this is from a 2019 um, article from the AMA, and it really is a repeat of what was very first published in 1994. So it states if coding for the fine needle aspiration, the study of cells is the intended procedure. When considering a specimen collected using a fine needle, I do suggest that you clarify the type of specimen that is submitted for examination. So the primary factor for the CPT selection is that you have a cytologic examination, which will be that fluid that contains cellular material, or you're going to have a histological specimen, and that's going to be tissue from a core biopsy. And material submitted for the FNA is going to include the slides to be prepared from aspirated fluid, and the examination is going to focus on the cellular level details. Now, in contrast to that, the removal of intact tissue is going to allow the examination to focus on the overall tissue architecture, and that is going to be coded as an 88305 generally, as opposed to an 88173 for your FNA. So it's really, are you looking at cellular content and commenting about the structure of the cell, or is it tissue and the architecture of the tissue? And those are your key looks for terminology in the report. So next here on slide 37, this is an actual email question. It is sort of a follow-up to what had been an ongoing conversation of what constitutes the materials to be received from a fine needle aspirate or a fine needle biopsy. And you can see by looking at this question, we've moved through a few conversations, but in this particular situation, the sample that was submitted was solely and fully submitted in formalin preserved fluid, and it was completely submitted for cell block preparation. Oops, let me stay there. So in this situation, then when I review it, I coded only for that cell block as an 88305. And I base that on the fact that it was submitted in formalin, and the preservative of cell structure is disrupted when placed in formalin. So formalin has this interference with the cytologic stains. It can lead to poor staining. It's just not what we would have for a cytology specimen. And therefore, that formalin fixed fluid, it was totally submitted for the purpose of the histologic examination based on what I could determine from review of this case. Now, when an FNA is prepared with slides and a vial of that residual fluid is submitted, and the pathologist then requests that you have that residual fluid, prepared for a cell block in addition to the FNA. Then I'm going to have my slides that are more than likely going to be either a PAP or a diff quick, maybe an H&E, that will be on the fluid and cellular material from the FNA. But I'm also then going to concentrate residual fluid and look at that on a cell block. In that instance, I would code an 88173 in addition to my cell block. But again, referencing back to the email question, what I received, that specimen was fully submitted as formalin fixed and was concentrated to a cell block. So I went strictly with 88305 on coding that. Now, this is where I started a little bit ago, and I started for my confusion. This is where, when you're having comparison of the surgical procedure and looking to verify whether you have a core from a fine needle biopsy or if you have an FNA, many times you can ascertain that based on the surgical procedure. But in particular, these procedures are frequent, not, well, I won't say frequently, but they have been identified as being incorrectly assigned to an FNA procedure, surgical procedure, merely because the definition is by needle and the biopsy or excision of the node or the biopsy of the salivary gland, the um, biopsy of the thyroid with a core needle. Somehow that gets picked up as the fine needle aspiration and is incorrectly coded for the surgery. So while I do suggest that you review and compare surgical approach when you have the opportunity to the pathology procedure, you do have to do your own due diligence and make certain that you agree with that surgical procedure. Okay, now then, we'll start moving towards the end of the conversation for today and looking at the cytopathology discussion. Again, staying focused on the FNA, but here we have an AMA CPT that was a frequently asked question from January of 2016. And this question on slide 40 is from that set of questions and was requesting clarification on coding of when an additional pass as part of a single evaluation episode could be reported. And I think the confusing thing here is that the person submitting the question specifically asked about 88172 being associated with a repeat immediate evaluation. But you will see on the next slide that the AMA did respond back and say no. The unit of service for 88172 is the evaluation episode. So 88172 is the entire episode, and this is not necessarily coded per pass as a billing situation. Per the instructional notes following this code, the evaluation episode represents a complete set of cytologic material submitted for evaluation and is independent of the number of needle passes or slides that are prepared. But a separate evaluation episode does occur if the proceduralist obtains additional material from the same site, but only if the next pass to that same site is based on a prior immediate adequacy evaluation from the pathologist that advises that we don't have enough material, right? So if it is an inadequate for diagnosis, and that response from the pathologist is returned back to the proceduralist, and then that decision leads to the need for another pass to obtain more material, now I have a billable unit of service. Or I have a billable unit of service if documentation shows that it is a separate lesion that is being aspirated. In either of those situations, though, I'm going to be looking at a CPT code of 88177. Now, from the AMA CPT code descriptions, we see that sometimes coders are challenged with when to code for the additional adequacy checks when material is obtained from the same lesion. And in fact, the proceduralist may be obtaining material in order to ensure that sufficient fluid or cellular content for additional ancillary testing, such as DNA or RNA, or for culture. Maybe there's additional testing that needs to be done, and they're not necessarily making those additional passes in order to get an adequacy check. So we do need to be familiar with the different reasons for why some of the proceduralist may be going back in for additional material. And the criteria for billing of an additional adequacy check is to confirm that subsequent passes are for obtaining material that occurs after the pathologist has evaluated material from a prior pass. So it's really necessary to evaluate all of that documentation and understand the intent to know if you have an additional separately billable evaluation episode that the pathologist needs to grade and evaluate as being either adequate or inadequate. If the intent is to go and pull additional material for other ancillary testing, then there is not a need for the adequacy check. So this is documentation that we would look to as far as knowing that I have a single site, right? I have a site A in both of these passes. I'm at the same station. I have pass one, I have pass two documented. 2 slides are being obtained. I have the aspirated material is submitted for evaluation and adequacy check. And then I have the start time and the notification time. Very good documentation, minus one thing. In my notification, the interpretation by the pathologist does tell me that I have cells present, but I do not see the words adequate or inadequate. So I don't know, based on that first pass, if that specimen could have been adequate for diagnosis or if it was based on a response of inadequate material for diagnosis, that second pass was guided. So again, this is questionable for me as to how I would have coded it. Personally, since I can't tell, I would have submitted a query back to my pathologist. Now, in this next slide, so slide 44, a separate evaluation episode has occurred if the proceduralist obtains additional material from the same site based on the pathologist reporting of inadequacy from a prior immediate evaluation, right? So same story here is I'm looking for whether I have material that is documented as adequate or inadequate. And those words are very key in order to be able to code for these scenarios. Now, on slide 45, we have a clinical vignette from 2011. And this is a 56-year-old male, chronic obstructive pulmonary disease, so COPD. We do have an aspiration being performed. And then we're closely following a previous aspirate specimen that was found to be inadequate for diagnosis, and the pathologist is asked to immediately evaluate the additional smears to determine if the specimen is now adequate to make a definitive diagnosis. So in this scenario, when I'm looking at that distinction of whether it is adequate or inadequate, I am again looking to those 2 words to be documented in the pathology report so that I know what I am coding for. Now, in this situation, again, I'm giving you a comparison of the surgical approach, and the CPT code is 10005. And then in comparison, my immediate evaluation and my fine needle aspiration. For one thing, in my surgical approach, I have an FNA procedure performed without imaging guidance. I don't have an additional add-on code, so there was no additional lesion that was aspirated. So as I look down then to my immediate eval, I'm going to go with an 88172. I did not see any documentation of additional adequacy checks, so I'm fine there. And then I'm going to code my overall diagnostic examination as an 88173. This is a question not so frequently asked of me lately, but it is a question that I come across every so often. Several years ago, this would have been a question I would have encountered frequently. But the adequacy check that is performed by a cytotech who is assigned to the surgical suite, and that adequacy check is provided back to the proceduralist before the pathologist makes a determination. That adequacy check is not a separately billable check. It helps move the procedure along, but it is not going to be separately billable as 88172, only when that adequacy check is performed by the pathologist and reported back to the proceduralist. Is that going to be a separately billable procedure? Okay. Now, these last few slides are going to be a review of pathology documentation or sample reports. And here on slide 48, pass 1 is documented as adequate follicular cells and colloid. So I have a nodule, inferior right lobe, thyroid, ultrasound guided fine needle aspiration, and my pass 1 is adequate. I don't expect to see any additional passes at that same location that would require an adequacy check. Now on the next slide, I have a report, I guess is what I'd say. I do have a report, but I do not have adequate documentation within this report to determine if the additional pass was performed at the same lesion. And I also do not have information to know if the second pass occurred before or after the pathologist reported out on the first pass. I personally would not code an 88177 as an additional pass here. The third pass here returns tissue, and that's going to be coded as a touch prep. Now on slide 50, and based on the information in the sample report, this would not have qualified for consideration of an F&A because I have touch preps. The material that is submitted for examination here is tissue. It is from a fine needle for a core biopsy. I've coded touch preps, and this is coded as a histology case. So I am not going to be coding for F&A on this particular case. All right. Well, thank you very much for selecting this presentation. And I hope this has been beneficial to you and that you found some of the information useful. And hopefully you gained maybe a little new knowledge as we went through the slides. So again, thank you very much for your attendance. And we hope to see you in Atlanta for ASCP 2025. Thank you.